Going to talk about home health services. Go ahead. Hey, Angie. Yes. Let me just slow down for a sec. So again, today we're going to talk about home health services. We're going to talk about home health not in the context of right or wrong, just in the context of let's understand what this service is, who qualifies for it, what really the best use for it is, and how do we make sure that we're able to ensure that those that are getting it get exactly what they need, and those that are approved and ready to get it, they're getting it for sure. And we want to make sure that if there's anybody that's potentially receiving a service that they're either not benefiting from or don't qualify for, we have an approach in mind for how to best support them in other ways. So to get started, the reason why we're talking about this today is we want to make sure that every patient that's getting home health services qualifies and really benefits from the service. This is going to be important because nationally there's quite a bit of inconsistency when it comes to the use or the chronic use of home health services for the treatment of a variety of different conditions. Now this is kind of nationally a big deal to the point where MedPAC and other agencies have really started to pay attention to home health services in the way that they want to make sure that only those that are getting it are really qualifying for it. And just about every single year, or just if not every month, you're going to find an article that talks about a region or home health agency that's getting into quite a bit of trouble for their use of services. Now, again, I'm not trying to say that anyone or anybody, for certainly not any of our agencies within Oklahoma, are intentionally bad or intentionally good. It's just we want to make sure that we have an understanding of the service and we're able to use some of these home health certification tools or recertification tools so that we can best understand and best educate not only ourselves and those within our organization, but the patients on what care alternatives are available or how do we make sure that we're getting the most out of that service. So to start with, not everybody is quite as familiar with what home health is. And I like to show this slide because I think it shows things that are good and maybe not as good. So on the left in that gray box are things that are commonly paid for by Medicare, and Medicare will commonly say this is an approved service. Now that ranges from medical social work, which we oftentimes don't think about, but can be a really valuable service, the wound care, the interventions, or the intravenous therapy, monitoring a patient that is really in a kind of a tough or potentially unstable health status, physical therapy, occupational therapy, skilled nursing care, or maybe even that home health aid that will come by part-time or on that intermittent basis. So those are things that Medicare will pay for. Not necessarily every patient will qualify for them, but those are things that Medicare says, these are right, these are good, these are things that I want to help to pay for and support through the home health program. Now there's things that Medicare does not want to pay for, or Medicare doesn't feel like are appropriate to be covered under the home health services. And these are things that I'm not trying to say anyone is intentionally bad, and there's oftentimes a misunderstanding about what should be covered. So transportation is one of those common things that I've came across that a home health agency feels like it's their duty to provide, or this is something they should be doing for a patient. That's not necessarily a service that Medicare believes that home health agencies should be providing or is really in their wheelhouse. So transportation can potentially be covered by non-emergent transportation services, and you're more likely to see this with a patient that has end-stage renal disease where they're potentially qualifying for that non-emergent transportation. That's a separate program. There's something designed to care for those patients that are truly bed-bound as opposed to just maybe a homebound home health patient and supporting them. There's some services related to end-stage renal disease patients and how can we best make sure that we're coordinating care for them or looking after those patients that are really close to the end of their life as they're dealing with kidney disease. Prescriptions is usually not something that's supposed to be covered as part of home health services. Prescriptions will normally fall under Part D or Part B programs, which is going to be separate than home health. And then the big red flag that I oftentimes see is housekeeping. Now, housekeeping can be great. Housekeeping can make a real difference for some patients. But housekeeping is not a service that should be performed as part of a home health certification, and not a service that should be performed and billed to Medicare as a home health procedure, as a home health service. Now that's not to say that any of those things in that pink box that are kind of that red flag box in the pink, that those aren't things that couldn't be provided by a home health agency, and maybe they're provided as a per diem, or they're paid by the patient directly to the home health agency. That's fairly common to see. Or sometimes a Medicaid program will provide those services as well, or a grant program will provide those services to a community as well. I'm just saying that those are services that Medicare on the right doesn't believe are appropriate, and they will not be paying for. So one of the challenging parts about home health services is it's a little bit different than just about everything else. We go to the clinic, it's one visit. We go to the hospital, it's one admission, one ER visit. A home health certification is a 60-day block, essentially, of care. So within that 60-day block of care, there's a lot of different things that can be covered, a lot of different things that can occur. So as we touched on in the last slide, there's a wide variety of different services that can be provided to a patient. Everything from medical social work, a home health aide, to physical therapy. And because there's that huge variation and huge range in services that can be provided, the actual costs associated with a home health certification can be pretty broad. And it can range from about $1,500 for that 2-month certification to close to $4,000 or more for that home health certification. I've even seen home health certs that have gone as $4,500 every 2 months. Now the reason why there's that huge variation in services is because home health is providing that wide variety of things. It's a little bit different in the intensity of care necessary for a patient that's receiving wound care services is different than the intensity of a patient that's maybe needing physical therapy, speech therapy, as well as others after they're recovering from a stroke. So because there's that huge variation in the cost of a home health certification, and there's a potential huge revenue opportunity on the part of some home health agencies if they're providing services that are at a greater acuity than the patient may qualify for or than the patient may need, it's going to be important to make sure that we're paying attention to what is on these home health recertification requests and how can we best support our practices, because we are essentially the orderers as our organization. So each provider is going to be ordering home health services for a patient. So this is going to be very similar to ordering durable medical equipment, ordering maybe a direct admission to a hospital, ordering a prescription for a patient. Ordering home health services is really the same thing. It's ordering care for a patient to receive. So we need to think about ourselves not as policing the home health agencies, but as being good stewards of the Medicare resources, because we're the ones that are potentially ordering this service. So as we're thinking about ordering the service and who's going to qualify for it, understanding patient eligibility is going to be a huge priority for us. Because just because a patient may want it, or the patient may even benefit from it, doesn't mean that the patient's going to qualify for it. So for instance, homebound status is going to be one of the more challenging, but also most important components of really understanding home health services. So with home health services, the patient needs to essentially be confined to their home. Now that's a pretty deep topic, and our next slide is just about that. But always keep in mind that if we're thinking about a patient that's receiving home health services, they have to be confined to their home, and that's why somebody's going to their home to provide that care. The patient must need skilled services, so they must need something more than housekeeping, meal preparation. They must need a true medical intervention. So we always have to make sure that we're thinking about home health services not in terms of right or wrong, in terms of what is the patient qualifying for and who's benefiting. And to really be qualifying for it, the patient must be under the review of a provider, and then be having, at least before the start of the care plan, a face-to-face encounter with a physician or with a nurse practitioner or a PA, just to make sure that that provider that's going to be signing off on that care to be delivered, they've seen the person and they've seen the patient, and they believe that this care, or this potentially home-based care, is going to be really necessary and is going to help the patient to improve. So having an understanding of all 5 of those, or how all 5 of those interplay, is going to be important as we think about which of our patients are going to best benefit from receiving home health services. Because it's not about right or wrong, it's about who qualifies and who's going to benefit the most. So as I mentioned, that homebound status can be one of the most challenging things to fully understand, or to understand how it applies to our patients. because if home health services are being provided, you shouldn't have a physical therapist, speech therapist, a home health nursing aide. They shouldn't be going to the patient's home if the patient could potentially be going to an outpatient clinic, could be going to an outpatient physical therapy center, could be going to an outpatient wound center, where it may take a little bit more time on the part of the patient, but we know that that's going to be a more cost-effective resource for the whole country and for the Medicare dollar, because it will allow that provider to see multiple patients over the course of an hour, as opposed to potentially driving between patients. So to qualify for home health services, the patient must be considered homebound. And to be considered homebound, the patient must either, because of some illness or criteria, essentially need a lot of assistance to leave their home, and that might involve crutches, canes, wheelchairs, walkers, or even like a person that has to actually help them do anything, or has to help them actually leave their home. Or they might have a condition that leaving their home is actually medically contraindicated, and they could be in health danger of some sort just by leaving their home. So just because you have a walker, have a wheelchair, that doesn't necessarily mean you're considered homebound, but that's one of the first two really criteria that we're going to think about is a patient considered homebound? Now the next thing that we need to think about, so if they have one of those first two that's in that left box, is there a normal inability to leave your home? And does leaving your home require pretty considerable and taxing effort? Now, one of the examples I've seen around this is related to going to church or going to get your hair done. And the example that I've essentially interpreted from CMS was that going to church on Sunday is going to have you essentially pretty tired and pretty exhausted until about Tuesday or Wednesday. You're not going out every single day. You're not going to bridge on a daily basis. You're not going to get your hair done on a regular basis. And certainly you're not going to be driving yourself very much at all. I mean, if you're driving yourself, I think that's really going to fringe into a gray area, and I'm going to be concerned. So usually if I'm advising a practice about use of home health services, if I'm thinking about homebound status, and if I have a patient that comes into the clinic that has maybe just had their hair done, or they maybe just had their nails done, then I'm going to pretty seriously think about, is this patient able to kind of move around on their own? And is this patient, essentially physically healthy enough to be able to function in some of those outpatient settings that they could maybe travel to? Because as we think about home health services, we're thinking about that medical intervention. That medical intervention is going to be different than a social intervention or a social encounter, because a patient shouldn't be signed up for potentially $25,000 per year service because it's inconvenient or they choose to not go to an outpatient physical therapy service. We really want to make sure that if a patient is receiving home health services, they're receiving services that they qualify for. And one of the ways that we know in which they're going to qualify for it is that there's going to be things that have to be written on the home health care plan that's going to indicate the level of services and the type of things that are going to be performed to the patient as part of that recertification or part of that home health certification period. It can be a pretty exhaustive list of different things that are out there, and I would say the things that are on the left in that blue box are going to be, from my experience, more pertinent or oftentimes more worth closely scrutinizing goodness, than the things that are on the right. The things that are on the right are usually going to be pretty consistent certification, although all are important. I would say I've had greater experience with some of the things that are on the left. So one of the things that I've talked about quite a bit was physical therapy and therapy services. Now, both of my sisters are physical therapists, so I think physical therapy can be awesome. And one of my mentors growing up was a home health administrator, so I think home health as a whole can be awesome. But understanding the use of physical therapy and understanding the use of rehab services in a homebound or home therapy basis is going to be really important, because if a patient has suddenly started to receive more and more rehab services, that's going to be one of the things that can really drive up our overall home health costs. Having an understanding of what activities are permitted is going to be important, because things should be improving over time. If you're receiving home health services on a very regular basis, I would start to think that the patient should really be getting better and should be improving. So their range and the scope of activities that are permitted should be getting bigger as every recertification request comes in. And that patient's prognosis should be getting better. Or there should be changes in the patient's prognosis, because this is meant to be an interventional level of care, not a home stabilizing, home hospice. This is a home, let's make you healthy, let's get you able to function independently on your own. Paying attention to those functional limitations is going to be the same thing as that prognosis, wanting to make sure that our patients appear to be getting better. And paying attention to did suddenly the frequency of visits change? Now, and I hate to be skeptical about any of these, because I think home health services can be awesome, when done the right way under the right care setting. But there's the potential that more services can be provided by a company, by an agency, because they know that there's an opportunity for a little bit more revenue. So hopefully that's not going to impact any of the agencies that we work with on a regular basis. But I do know that from some of the agencies that I've worked with, that's a tendency that can occur. So we want to do our best to make sure that we're paying attention to those couple of those things that are on that recertification request that'll come in, to make sure that we're best positioning our ordering provider to be successful. So when we're having these recertification requests come back in, and that's one of the kind of nuances of home health care, is as we think about one visit for a clinic visit, the patient goes to the clinic and they do their one visit. If they're going to receive an MRI, we write one order and the patient gets one MRI. Or we're going to get a recertification request every about day 55 for those to recertify the patient for the next 2-month period. So from my experience, having somebody that really is the team member that probably provides the biggest support or almost level of oversight to the process can make a huge difference. Now, I've joked that this person is like your research czar or your home health czar, but it doesn't need to be quite that level. It's just somebody that has to be responsible for making sure that we're gathering these up, maybe supporting those ordering providers to ensure that they're going to be successful, and then having a team member that will maybe help to do some pre-screens of those forms for our providers. Our providers are very busy, stretched about as thin as they possibly can. So if we can have a team member that goes through and maybe highlights or identifies some things that are potential red flags that we want to make sure we're paying attention to, that can help the provider focus on other things that are maybe a little bit more critical or a little bit more acute. And then I would say that when reviewing these recertifications, it's important to do it on a pretty regular basis. Now, an issue that I've ran into in the past is, do recertifications start creeping in later and later and later? Rather than getting it on day 55 through day 65, are we going to get it on day 75, 85, 95, or 100? Now, when we start getting those delays in those recertification requests, that's going to be a real red flag for me. And we need to make sure that as a clinic, we're positioning ourselves to be successful and reviewing those recerts on a pretty regular basis to prevent them piling up or potentially not intervening on things as soon as we should, because we allowed them to essentially pile up. And by establishing your own review process for looking at recertifications, it's going to help to make sure that every home health recert that comes in, it's going to that every patient that receives a service is going to qualify for it and going to benefit from it. And it's necessary because taking these steps to make sure that we're reviewing every order is the best way to prevent a perception or actual Medicare abuse. Now, when I say Medicare abuse, I'm not talking about physical harm or somebody going out and hurting someone. When I'm referring to Medicare abuse, I'm referring to taking advantage of the system or potentially doing something that would be kind of fringing up against that fraud category. It's not meant to say that we're doing something that was intentionally malicious. If we're doing something that is outside of what Medicare wants to pay for, then we're going to be fringing on abuse. And that essentially every time as an ordering provider you're signing for a home health service, it's the same as ordering an MRI, ordering a CT scan, admitting a patient to a hospital. It's saying that we believe that this is the best medical care for the patient, and we understand the qualifications as well as the care that's going to be delivered. So to help you with this process, a couple tools that I think are really beneficial are to use these two recertification forms. Now with these recertification forms, what they're intended to be is support for this extensive and at times cumbersome document that is a 485 or that recertification request. Because we know that that recertification request can be really overwhelming as every agency has started to adapt their own EMR or their own way of doing things. Things have become very templated, and it's quite possible for that recert to look almost identical period over period. So having these couple tools, or maybe one of these tools to help you out, can make a real difference. So the one on the left is a tool that's going to be more patient facing, and I would say this is a tool that you might be using to ask patients how they're doing. Ask patients if it seems like the care being delivered matches what the agency is saying that they're doing. Things along the lines of, what are they doing for you? Well, it turns out what they're doing for me is they come in and they have coffee because they wanted me to do squats, but I didn't want to do squats. Squats were hard and not very much fun. So rather than doing squats, we're going to do this instead. That's going to start to fringe into that. Okay, the agency is saying that they're providing services X, Y, and Z, but the patient will only confirm service A. And then the 485 support tool is a tool that we developed to support providers that were tending to let those things let their recertification requests pile up on a Friday afternoon. And this forced them to kind of slow down and identify what are the steps that are in this recertification that we need to make sure we're paying attention to month over month. And the things that are in here that we want to make sure that are validated either in our EMR or visit notes of some sort or in that 485. So we want to make sure that if there's a change in care plan, we have documentation of why things changed. Not just the agency determined that we needed to raise the level of acuity or raise the care that was being provided to our patients. So as I'm thinking about recertification requests, the things that stand out to me are for potential red flags. I really want to be paying attention to any potential changes in diagnoses. If it seems like suddenly the reason why the care is being provided changed without a directive from the ordering provider, that's going to be a huge red flag for me, and I'm going to want to make sure that that's confirmed somewhere. As I mentioned earlier, if we're starting to get patients that it seems like they just really plateaued and they're not improving as much as we thought they would, that's going to be a real issue for me, and that's going to be something that I want to dig into a little bit deeper. Maybe home health services is not the right level of care that the patient should be receiving, or maybe we need to think about which agency is providing care for the patients. Did suddenly the level of services escalate without adequate documentation? Because if the level of care escalated and it didn't seem like there was appropriate documentation around it, that can be another kind of red flag for us that we need to be thinking about, because agencies know that some services and some diagnoses will pay a little bit more than others. So there's always that potential that they could raise the level of services or raise the diagnosis without confirming with us first. I'd always be important about any lack of documentation or lack of changes in documentation. As I mentioned a little bit ago, that because of EMRs, because of things that have been perceived as improving effectiveness, it's also created the ability for very standardized period over period essentially duplication through the use of templates. So this was something that we identified with one of our regions, where the home health agency was essentially period over period providing the same notes, the same documentation for the reason why the patient was continuing home health services. We felt like, you know what, shouldn't something have changed? Shouldn't there have been some improvement? And we brought that up to the agency, and it got a little better. And then we decided we need to push everybody on this and pay attention to even more people. And one of the things that stood out to us was that we started to identify that some agencies, and this was a little bit harder to catch, would do in January documentation A, in March documentation B, in May documentation A, in July, documentation B. And they would essentially go back and flip-flop every certification period which set of documentation they were using. That's going to be a little bit harder, a little bit longer to catch, but I would just start to maybe pay attention to if you're noticing that if cert period over cert period things look the same, that's a huge red flag to me. I would really pay attention to, are we starting to get delays? Because as those agencies may realize that we're starting to pay a little bit closer attention to this, they may start to delay how quickly they send those recertification requests back to us. Now that's something that can be a huge red flag and a huge issue for many of us, because the same way that we would not want a patient to receive a prescription without signing off on it, we wouldn't necessarily want a patient to receive a home health service that they don't qualify for, or that they're maybe not benefiting from, or maybe we even want to change the way the care plan or the level of services that's being provided without our input first. So just because care is being provided, so for instance, if a patient goes on a home health certification, on for January, on for February, and we didn't get the recert request until April, even though the patient received care in March, if we didn't feel like it was medically appropriate, you do not need to sign off on that. So that's important to keep in mind. Of agencies will start to feel like, well, I've been providing it and I've been doing it. Just because something's been being done doesn't mean it was necessarily appropriate or should have been done. So I would make sure that we're really paying attention to any delays in recert requests, and really pay attention to dates and service. If it seems like a patient has been chronically receiving the services, maybe been on for 6 months, a year, 2 years, 4 years, let's make sure we're identifying, does the patient still qualify? Is the patient improving? And is the patient getting the care and the outcomes that they need? Maybe they're receiving a higher level of service than they need. If it's possible for the patient to perform outpatient physical therapy independently, or maybe perform physical therapy on their own after being educated on the exercises that they're supposed to do by the physical therapist, but the patient still maybe needs aid work. So that's a big difference in the level of care and the type of services that are being provided. So as I'm thinking about what's a good home health agency, because many of you are probably sitting here listening to this going, you're essentially almost asking me to audit every recertification request that comes in. Unfortunately, I'm not saying audit, but I want you to maybe place a little bit closer look on. The things that would be really important for me as I'm thinking about home health agencies are we getting timely communication? Does it seem like the information that's coming to us is getting to the providers, the person that's supposed to be ordering the care, on a timely basis? Because if we're getting significant delays, or we're not getting those blood pressure measurements or those A1C readings the way we expected to, that's going to be a red flag for us. Are the providers contacted as patients are going to the emergency department or having ED visits or having admissions? If we're not notified right away, that's going to be hard for us to intervene, maybe even do those transitional care management visits. If we're responsible for the care because the patient's left the hospital and we've decided to co-treat with a home health agency, we need to make sure that we as PCPs are being very aware of any care that's being provided. I would start to really pay attention to, if you have an agency that decides they're not going to just recert everybody, that's huge. To me, that's a huge win, because I know that that's somebody that is looking to partner with me because they understand the importance of not just doing a blanket or not just recertifying patients across the board. And having that understanding of, or that partnership that we're able to develop with a different agency, is going to be really important if we start thinking about going to phase 2 or phase 3 of our home health integration, where we're partnering up with those that really would be good partners for us. Patient is always the most important person when we're thinking about home health services, and we want to make sure that the patient is having noticeable improvements month over month, or it seems like there's some level of positive changes that are occurring. Because if it seems like our patients are not benefiting from the services, now we really have to evaluate, okay, why is this patient receiving the care? Are they still benefiting? And are there care alternatives that might be available? And I think just the same way I said that patient decided that they prefer to have coffee as opposed to receiving home health services, identifying that having the patient be able to identify the services that they're receiving is going to make such a difference in terms of best promoting the home health services for the patient, or best promoting a home health agency back to us. It's important that the patient can identify what is being done to them and what is being done for them or with them in order to best justify the care that's being delivered to them. So as I'm thinking about home health certifications, and I said that I wanted everybody to take a little bit closer eye on the care that's being provided. The things that I want you to keep in mind as you're thinking about potentially removing a patient from home health is it's always important to make sure that we're talking with that patient first. The same way that I said I want to confirm with the patient, what services are you actually receiving? Speaking to the patient before potentially taking them off makes such a difference, because it allows for us as the care team to really direct the narrative. And that sounds a little malicious to say, but unfortunately I've had experiences of we work with the providers and they've started to better understand which patients are qualifying for the service, and they've started to be really proactive about understanding which patients should be receiving services, but they removed the patient without telling the patient why they removed them, either by phone or in person. And that allowed for the agency to say, you know what, I guess your doctor doesn't feel like you need this anymore. I guess your nurse practitioner doesn't feel like you need this anymore. Well, I can find somebody else that'd be willing to do it for you. And by us not being assertive and us not really kind of owning that experience with the patient, it allowed for the home health agency to own that experience with the patient. I would always consider ordering a medical social worker. Not every agency offers this. From my experience, it's about half to 3/4 of agencies offer it, but you'll be able to identify that on homehealthcompare.gov of which agencies offer a medical social worker. But they may have additional resources or additional tips that they're aware of in the community that might help the patient to thrive independently. I would make sure that you're documenting any discharge orders that you're giving. I would document them first in terms of sending a fax or an electronic order to the agency, but also document them in some sort of a logbook for yourself. Maybe even confirm a receipt of the discharge notification. Because we've had services or experiences where providers have tried to remove patients from home health, and the home health agency did not remove the patients from the home health the way we first expected, and whether it was they just did not receive it or they behaved in a way which caused us to believe they did not receive it, patients continued to receive the services, and the agency just kind of went along doing the patient was not supposed to continue to receive the services, but the agency continued to provide it. So always make sure that we're paying attention to our discharge orders, and really paying attention to did the agency get it, and did the agency stop providing the care to the patient. I would always start to think about, are there care alternatives that are out there? Because if we're potentially removing a patient from home health because maybe they don't qualify for it, but they need a little something, maybe we can think about chronic care management or potential outpatient services as a way to make sure that that patient is able to thrive as independently as possible. I would make sure that we're following up with our patients on a pretty regular basis, just to really make sure that they're doing okay and they're doing the best they can while they're at home. And one of my providers, through doing a visit like this, identified that home health services was continuing to be provided as Dr. B went to go see his patient, and when Dr. B went to go see his patient, it turns out that the agency was still providing the care that no longer was supposed to have been. And it was that Dr. B was prepared for, are you doing okay? I know we took you off. Is everything going all right? And the response from the patient was, oh yeah, no, they're still coming. And that's an example of, sometimes we might do everything right and someone else doesn't. But it's important to make sure that we're checking in with our patients on a regular basis to make sure that they're doing okay and they're doing well while they're at home. So to make sure that you can be as successful as possible with this, I would say make sure that you're tracking your research. Contacting your patients either before you're removing them from home health services, or for sure before, but then also probably shortly after, just to make sure that they're doing okay. Use your screening tools. And what those 2 screening tools that we had a few slides back, we're going to send those out to the group a little bit later today. And then perform TCM visits as a way to identify maybe a patient that's receiving a service that we can kind of redirect early on. So if you're seeing a patient on day 10 after they're discharged from the hospital, maybe the patient is actually doing much better than they first expected and no longer needs the home health services the way they first thought. So identifying patients that are receiving home health through those TCM visits can be a great way to prevent that 2nd, 3rd, 4th, 12th certification from occurring. So I apologize we got started a little bit late, and we moved at probably a fairly good pace because of that, but I did want to leave a little bit of time for everyone for some questions. So with that, I'll pause. Is there any questions